Hello and welcome to this week's Health Report with me, Norman Swan. According to an Australian study, young children with asthma are either being wrongly prescribed or overprescribed a costly, potentially non-beneficial and possibly harmful inhaler. Nusrat Humaira is a respiratory epidemiologist and a senior lecturer in paediatrics at the University of New South Wales and Sydney Children's Hospital. I spoke to her earlier.
Thank you, Norman.
How common is asthma in children?
Asthma is the most common chronic condition in children all over the world, not just in Australia. In Australia, we have a particularly higher prevalence of childhood asthma. Probably 1 in every 10 to 11 school-age children have an ongoing diagnosis of asthma. So that's how common asthma is.
That's enormous. I thought it was 1 in 20, but it's 1 in 10. I mean, that's extraordinary. Now, we should just do a primer in asthma treatment because people think about the blue puffer, the Ventolin, and one of the problems is that people rely too heavily on the blue puffer rather than preventer medications. What's the sign that a child should be on a preventer medication rather than the blue puffer, which opens up your airways?
There's two inhalers that's commonly used in children with asthma. So the one, the blue puffer, which you mentioned, which is like a reliever puffer. The child has acute symptoms, breathlessness, the child uses that puffer.
Which doesn't do anything about the underlying condition.
No, it just sort of, elevates your symptoms at that point. And then there's the other puffers, which are the controller or the preventer medications. And they are mostly the inhaled corticosteroids commonly used in children. And then there's the other one, which are the fixed dose combination of two inhalers. There's the inhaled corticosteroids, and then there is a long-acting muscle relaxant, so the LABA medication. The blue puffer has a short-acting one, and the fixed dose combination has the long-acting one in combination with the steroid as well.
And essentially, if you've got a child whose symptoms are not being well controlled with the blue puffer, or they're taking it a lot each day or each week, they're waking up at night, then that's the sort of sign that they need a preventer medication of some kind or a controller of some kind.
Yes.
And your problem is this fixed dose combination where you've got the long-acting beta agonist, or the long-acting version of the blue puffer, and the steroids. That's the one you've got a problem with.
The national and the international guidelines do not recommend the use of fixed dose combination in under 5 children, so in the preschoolers. And in the children age 6 or higher and the adolescents, it is recommended only after initial therapy with the inhaled corticosteroid have failed. So in our study, what we have seen that it's still being given to preschoolers, which is not at all recommended in any guidelines. And the other surprising thing is, even though the dispensing pattern for fixed dose combination inhalers is coming down, it's generally almost always given to children without an initial trial with the inhaled corticosteroid.
And what's the problem? Obviously, they cost more money. I mean, there have been concerns that the long-acting beta agonists are problems. Are they a problem in children, or are these drugs safe?
Before I answer that, I just want to talk a little bit about the cost. These are not fully subsidized medications. So there's almost 40% of the cost that is actually borne by the parents. So the parents have to pay for the medications. So that's also an issue. And coming back to the adverse effects, so for the preschoolers, the fixed dose combination therapies have never actually been trialed out. So we have no data from any clinical trials suggesting that they are actually beneficial in the under 5s. And there's some data that suggests that in older children, it can actually have increased risk of hospitalization and can even cause tachyphylaxis, increasing resistance. Yes. However, there's also some data suggests that fixed dose combination inhalers can be actually beneficial as a step-up approach in adolescents, not so much in the 6 to 11 years, but more in the adolescents. So that's the problem with fixed dose combination. We don't have enough data from trials to suggest that they're beneficial. In fact, many systematic review have shown that they did not yield any better outcomes in children compared to inhaled corticosteroids. And of course, cost is a huge problem.
And of course, the interesting thing here is that childhood asthma is not the same disease as adult asthma, maybe even as adolescent asthma. It's a different problem.
Exactly, yes. And there's also the combination of viral induced recurrent wheeze, and diagnosis of asthma in under 5 is very complicated. So I think oftentimes physicians might get tempted to follow the same sort of treatment protocol, but it's essentially not the same.
So what's the question that a parent needs to ask? And of course, you've got to be patient with inhaled corticosteroids because it takes a while for it to work, whereas the attraction in the combination is because it's got the long-acting beta agonist, you'll feel better to start with, but it's not necessarily doing you good. How patient do you need to be with the inhaled corticosteroid?
Once you start a child with an inhaled corticosteroid, you should essentially monitor the symptoms over 4 weeks. If the child is improving, then you bring down the dose, and then you again do a review in 3 months. And if the child has improved, you can potentially even stop the inhaled corticosteroids. But if in that 4 weeks period the child is not improving and night symptoms or day symptoms, and the child is requiring to use the blue puffers a lot more, then obviously there is the need for a step-up approach, which could be potentially a higher dose of inhaled corticosteroids or even a fixed dose combination inhalers, depending on the response with the initial therapy. As parents, they should, when they're prescribed an asthma medication, asthma inhalers for their children, they should inquire these details, that whether it's a fixed dose combination inhaler or a inhaled corticosteroids, and try to get a little bit more details of why they're being prescribed.
And if you're hit with a big bill at the pharmacy, you'll have a sense that you might be on the fixed dose one. Nusrat, thank you very much for joining us.
Thank you so much, Norman.
Nusrat Humara is a respiratory epidemiologist and senior lecturer in paediatrics at the University of New South Wales and Sydney Children's Hospital. This has been The Health Report. I'm Norman Swan, and I hope you can join me next week.